I'm not going to talk about pharmacology or MMEs. I know you're desperate to hear all this. I'm not going to talk to you about how many pain pills you should prescribe after surgery, anything like that. I'm going to try to lay out sort of the history of this opioid business that's in a relevant time frame for us, and then kind of let you make your own decisions, you know. So my financial disclosures and all are the same as before. Today's plan, talk to you a little bit about the history of this pain treatment specialty and the use of opioids, tell you a little bit about the prevalence of substance use disorder and opioid-related mortality, talk a little about intraspinal opioids as a better alternative to high-dose parenteral opioids. And we'll talk a little bit about the considerations of kind of responsible perioperative prescribing. So there are a lot of biases. I want you just to think about the intrinsic biases around treatment of pain, you know, because you can't see it, we can't feel it when somebody else is having it. And, you know, we all have biases about in life, and those are not any different with respect to people and conditions like pain. And one of the famous biases that's talked about a lot is this situation of Queen Victoria, where her obstetrician said the following: painful contractions during labor are natural and physiological forces that the divinity has ordained us to enjoy or suffer. Well, interesting. And that was Professor Charles Meigs, who was the obstetrician to Queen Victoria, who was, as is often the case and relevant today, a middle-aged white male. So this fellow on the left, James Young Simpson in Edinburgh, discovered the use of chloroform to anesthetize people, and Queen Victoria said, well, maybe that would be useful in childbirth, and Professor Meigs